Hello friends, so welcome to today's test and discussion session of pharmacology. So let's go to the first question. Analyzing the dose response curves in the graph where response is plotted against the dose, that is a log scale, which of the following statements is correct? So you can see here on the options, drug X is least potent as it requires the highest dose to produce effect. Drug Y shows the highest efficacy compared to X and Z. So before we go into the options, there are two terms that you should know. What is meant by potency and what is meant by efficacy. Okay. So first let's see what is this graph or curve. This is a dose response curve. So what is meant by dose response curve or DRC, where the logarithmic of the dose is plotted on the x-axis and the response is plotted on the y-axis. Okay. There are actually two types of DRCs. One is called as the quantile DRC, the other one is the graded DRC. Quantile DRC is when you have a all or none response. Like in case of antiemetics, whether it stopped vomiting or it is still continuing. So it's a yes or no response. We get this quantile DRC and we get from this quantile DRC, we get something called as ED50, that is effective dose 50, the dose which is effective in 50% of population. LD50, which is lethal, the dose which is lethal or which kills 50% of population. And the therapeutic index and all is calculated with the help of a quantile DRC. Now, what is graded DRC? In conditions where you have a graded response like reduction in BP, what you get is a graded DRC. So we have two types of, we'll come back to the question after discussing the key points. So we have two kinds of DRC. One is simple DRC where the response is plotted against the dose. Okay. And we have the log DRC where the response is plotted against the log of dose. So what is the difference between simple DRC and log DRC? In case of simple DRC, the shape of the DRC that we get is a rectangular hyperbola, and in case of a log DRC, it is a sigmoid curve. So what is the advantage of making it into a logarithmic curve? As you note here, the mid portion of this graph is a straight line. So for comparison between two drugs, the DRC of two drugs, it is always better we get a straight line. So here the mid portion or the intermediate portion is a straight line. Hence, it is more easier to compare between the drugs. Another advantage is when you convert it into the log scale, a wide range of doses can be plotted on the same graph paper. So these are the two advantages of doing a log DRC. Now, what are the uses of log DRC? You can find out three things. One is the potency, the other one is what is called as the efficacy, and you get information from the slope of DRC. Now, what is meant by potency? Potency is the minimum amount that is required to produce an effect. For example, so you can compare the efficacy potency. You can distinguish between competitive and non-competitive antagonism, and you can find out the therapeutic index or the safety margin of the drugs. So what is meant by potency? The amount of drug that is required to produce a certain response that is represented by the position of DRC on the dose axis. For example, let's draw a log DRC. Okay, where log of dose is plotted against the response. We have a drug A and a drug B. So what is meant by potency? It is a minimum amount that is required to produce an effect. So if you take 50% of response and if you draw a straight line, A required this much dose to produce that effect, whereas B required this much dose. So which is more potent? A is more potent than B. Okay, so potency means it's a minimum amount that is required to produce an response, and if the curve is more towards the left, the drug is more potent. So here A is more potent than B. Is that clear? Is that concept clear? Now we come to the next term, that is efficacy. So what is meant by efficacy? It is the maximum response that we get from the drug is what is called as the efficacy. So efficacy is represented by the height of the DRC. So you can see here the maximum efficacy here is for B. So this is the maximum response for B and this is the maximum response for A. So in this graph, B is more efficacious than A. So efficacy is the maximum response that can be given and it is represented by the height of the DRC. So we have learned about what is potency and what is efficacy. Now what does this slope indicate? So we have, for example, we draw the DRC of two drugs. Let's say this is furosemide, which is loop diuretic, and this is the DRC for hydrochlorothiazide. Okay, so which one is more safer? I would say it is hydrochlorothiazide. Why I would say it is more safer? Because over a wide range of doses, you don't get much change in the response. The response is almost remaining the same. Whereas in case of furosemide, even a small change in the dose, you can see a wide variation in the response. So if a drug with wide pharmacokinetic variation and all, it is better to give a drug with a lesser slope rather than giving a drug with a steep slope. So that is the significance of knowing about the slope. Now, we have seen here, you can distinguish between competitive and non-competitive antagonism of drugs. How can we do that? In case of what is competitive antagonism? Where you have a substrate, you have a antagonist. The antagonist is similar to the substrate. So it competes with the substrate for the same binding site on the receptor, same active site on the receptor. There is competition between the substrate and the antagonist. So here, what happens is, if this is a normal graph, in presence of a competitive antagonist, this will how the graph will look like. That is in presence of 1x, 2x, it's a dose of the antagonist. So as you increase the dose, what do you see? The maximum efficacy is still obtained, provided you increase the dose of the, if you increase the dose, you will be able to get the same efficacy. This is because once you increase the agonist level, it can displace the antagonist from its binding site because the antagonism is surmountable. Okay, competitive antagonism, it is surmountable. When you increase the dose of agonist, you can displace the antagonist from the binding site and can produce the effect. So here, so the efficacy is remaining the same, but what happens to the potency? Potency decreases. So initially without the antagonist, if this is the dose required to produce this response, in presence of antagonist, you can see there is more doses required to produce the same effect. So there is shift of DRC to the right in presence of a competitive antagonism. In presence of a non-competitive antagonism, what is non-competitive antagonism? There is binding of the antagonist to a different site, not the active site, an allosteric site, and there is alteration of the receptor structure as such. So even if you increase the dose of agonist, however much, some of the receptor have lost its activity and there is a decrease in the efficacy. So there is flattening of DRC in case if this is the normal graph and this is a graph in presence of increasing dose of antagonist, you can see there is a decrease in the efficacy because however much you increase the dose, that the receptors that have been bound uh, by the antagonist cannot be active again. Okay, and but the potency is remaining the same. So there is flattening of DRC, but the potency is remaining the same. So by using this DRC curve, you can differentiate between competitive and non-competitive type of receptor antagonism. So, and the third use is finding out the therapeutic index or the safety margin of the drug. That is, what do? You draw a graph and one will be a DRC for therapeutic effect and one will be a DRC for the safety effect or the adverse effect. So there will be a minimum dose on which you get a desirable effect, and there will be a maximum tolerable dose above which you have unacceptable side effects. So the difference between them is what is called as the therapeutic range. So if this therapeutic efficacy DRC and dose is very narrow, it means the drug is less safe. The safety margin is low. So all these things can be obtained by looking at the log DRC. So now let's come back to the question here again. So what is asked here? From you have three drugs X, Y and Z. So let's see, if you take 50%, you take a response here. So which one will be most potent? It is the drug X which is most potent. So X is most potent, right? And which is most efficacy wise? X and Z are equally efficacious, right? So based on that, drug X is least potent, which is a wrong answer. Drug Y shows highest efficacy, again, which is wrong answer. Drug Y shows the least efficacy. Drug X shows the highest potency, which is true, as it requires the lowest dose to produce the 50% response. Drug X and Y have similar potency. No, X and Y is not having similar potency. X is less potent than Y. So that is also a wrong statement. So which is a correct answer here? It is option C, which is drug X showing the highest potency. Is it clear? Okay. Now let's go to the next question. In a patient with nephrotic syndrome, medications are often given in lower doses compared to a healthy individual. What is the most likely reason for this adjustment? What would be your answer? Increased hepatic metabolism, decreased renal excretion, increased protein binding, or decreased protein binding? So what is this patient having? Nephrotic syndrome. What is nephrotic syndrome? It's a condition where there is increased proteinuria. The protein is lost in urine. Okay. So there is proteinuria. So the plasma protein levels are decreased, right? Including albumin levels are decreased. So what happens when your plasma protein levels are decreased? What is importance in for plasma proteins with that of drugs? The drugs actually bind with this plasma proteins. Okay. And the drug exists in two forms. One is the free form, the other one is the bound form. Which is the active form of the drug, free or the bound? It is a free drug, which is the active one, and the bound drug is like a reservoir. Okay, so when the plasma protein level decreases because the protein is getting lost in the urine, the bound component is decreased and the free component is increased. So what can it result? It can result in toxicity. Okay, so in presence of nephrotic syndrome, since the free component is increasing and there is chance for toxicity, what you have to do? You have to decrease the dose. So we have to lower the dose compared to a healthy individual because there is decreased protein binding because the protein is lost in the urine and the free component gets increased, that can lead to toxicity. So we need to give a lower dose. Is that clear? Now, what is the significance of this plasma protein binding? You know, all our drugs, the acidic drugs, it binds with the albumin. Which are the acidic drugs? CNS drugs, penicillin, sulfonamides, warfarin, aspirin, all binds with the albumin. And whereas the basic drugs like TCAs, tricyclic antidepressants, opioids, beta blockers, amiodarone and all, they bind with the alpha-1 glycoprotein. Now, what is the significance of this plasma protein binding? You can remember the 4 Ds. One is distribution. If it is bound with proteins, what happens to the distribution? the drug is bound with the protein. So this together will act like a large molecule and they remain within the circulation. They won't go into the tissues. So what happens to the volume of distribution? Volume of distribution is decreased when there is increased plasma protein binding. Okay, so that is one significance of plasma protein binding. Another one is in case of it can cause displacement reactions. What is meant by displacement reaction? If we give a drug which is highly bound with the protein, we give another drug that is also having high plasma protein binding. What will happen if you give these two drugs together? For example, aspirin and warfarin. Aspirin is an NSAID. It is highly protein bound. Warfarin is also, it is an oral anticoagulant. It is also highly protein bound. So when you give them together, aspirin displaces the warfarin from its binding site and the free warfarin level increases. That can lead to warfarin toxicity. Okay, so it can lead to drug-drug interactions. The displacement can lead to drug-drug interaction. Another significance is duration of action. What happens when the drug is bound to the plasma protein? It is a free drug which is active. The bound drug is like a reservoir. So when the plasma protein binding increases, the duration of action of the drug is increased. Another significance is for dialysis. If it is bound to plasma protein, is it dialysable? No. So it won't be effective if the drug has high plasma protein binding. So these are the clinical significance of plasma protein binding. So you can see here, one is they behave like a large molecule, stay within the plasma, hence low volume of distribution. The drugs like warfarin, benzodiazepines, digoxin. Then drugs with high plasma protein binding will be long acting because it's a free drug which is active, not the bound form. And then it can undergo displacement reactions. That is, a highly plasma protein bound drug can displace another drug which is highly bound. That can lead to drug-drug interactions. And this we have already seen in case of hypoalbuminemia, like in case of nephrotic syndrome. What happens? The increased fraction of free drug that can lead to toxicity. So we may need to reduce the dose in case of nephrotic syndrome, and dialysis, it is not effective for drugs having high plasma protein binding. Now, what is the significance of drug distribution? One is the plasma protein bound. So if it is highly protein bound, it will remain within the circulation. It will not have high volume of distribution. So high plasma protein binding will have low VD. Another factor that determines distribution is lipophilic, because all our membranes are lipid bilayer. So lipophilic drugs tends to have a larger distribution or larger volume of distribution. Another factor that affects the drug distribution is the blood flow. If it is a highly perfused tissue, the distribution is also better to those tissues. And there is difference in the affinity between the different tissues. Certain drugs are highly effective for certain tissues, like digoxin is highly effective or high affinity for skeletal muscle. So they get distributed to those tissues. So they bind with the specific tissue. So all this can affect the drug distribution. Okay. So remember, plasma protein binding, there are four important things. One is the distribution, that is low volume of distribution. Another one is a duration of action, it is prolonged. Third one is a displacement reaction. Fourth one is a dialysis. And in case of conditions where there is decreased plasma protein, it can lead to toxicity of the drugs. So let's go to the next question. Okay. So here you can see an image, and in a research lab, 3 different GPCR ligands show the following effects. What is meant by GPCR? G protein coupled receptors. And what do you see? Ligand A, it increases the intracellular calcium. So ligand A increases the calcium. Ligand B decreases the cyclic AMP. Ligand C increases the cyclic AMP and activates pKa. So based on the signaling pathways shown in the image, these ligands are most likely to act through which G protein pathways. So you can see here, it has, this ligand has stimulated the adenyl cyclase, increases cyclic AMP, increase protein kinase A and increase the phosphorylation of proteins. Here you can see it has activated phospholipase C and there is IP3-DAG pathway that has increased the calcium release, again increased the protein phosphorylation and activated the calcium binding proteins. And here you can see there is again adenyl cyclase and cyclic AMP is increased in this situation. Okay, actually it should have been decreased of protein phosphorylation. So which are these ligands? So before we go into whether it is GI, GS, GQ, let's see what is G protein coupled receptors and then we'll come back to this. So what are the G protein coupled receptors? We have 4 important types of receptors in our body. So one is the inotropic receptors where the receptor is surrounding ion channel. Then we have a G protein coupled receptor where the receptor is attached with the G protein. Third is the enzyme linked receptors like tyrosine kinase receptor where it is attached with the enzyme and the binding of the ligand will activate the enzyme to produce the result. And then you have a nuclear receptors which go and interferes with the DNA transcription and brings about the action. Among these 4 important types, which is the most prevalent type of or most common type of receptor, it is the G protein coupled receptor. Why is it called G protein coupled receptor? Because it is attached with the G protein that has got an alpha, beta, gamma subunit that is attached with the GDP when it is inactive. When it gets activated, this GDP is converted into GDP. Okay, so it's the largest family and it is associated with G protein to produce response. Hence, it is called as G protein coupled receptors. And it is fast acting. Within seconds, you can get the result. Is it the fastest acting? No. Fastest acting is the inotropic receptors, which are the ion channels bounded receptors are the fastest acting. The second comes the G protein coupled receptors. So examples are alpha and beta receptors. You need to remember which are the examples of each of these types. So these are also called as heptahelical. You can see the 7 transmembrane domain receptors are there. Hence they are called as heptahelical. Since they look like a snake, they are called as serpentine, also known as metabotropic receptors. So as I said, it has got alpha beta subunit with the GDP attached. So when it gets activated, when the ligand binds here, it gets activated, the GDP is converted into GTP and you can get the splitting of this subunits. The alpha along with the GTP will produce certain kinds of reactions. The beta gamma produces certain kind of responses and then it comes back to the inactivated stage with the help of regulator of G protein signaling. So when the ligand binds with the G protein gets activated and there is stimulation of various proteins causing cellular response. Now we come to our question part, the different subtypes of G proteins. So you have GS, S you can remember for stimulation. Okay, so what does it do? It stimulates the adenyl cyclase and increases the cyclic AMP and hence the calcium channel opening and out. Example of this GS subtype is the beta receptors. Then we have the GI can remember I as inhibition. So it decreases the adenyl cyclase activity, decreases the cyclic AMP and the potassium channel opening. Now GQ acts by the different mechanism, that is activating phospholipase C, IP3DAG pathway, and there is increased calcium signaling. So that is how GQ, an example for GQ is your alpha 1 adenoreceptors. It causes vasoconstriction. You can remember that vasoconstriction. So contraction, there is increased calcium, which is in turn by DAG IP3. Then you have G1 2 bar 1 3, that is the thrombin receptors. They bind with small GTP binding proteins like Rho proteins, and there is GO, which are M2 receptors that acts by inhibition of the calcium channel, so direct action on the ion channel. So you can see here, when GS is stimulated, the cyclic AMP levels are increased by stimulation of adenyl cyclase. So that will activate the protein kinase and there is phosphorylation of proteins. When GI is activated, there is inhibition of adenyl cyclase, there is decreased cyclic AMP. Okay, and that brings about a different set of actions. Now when you have GQ, you can see here the phospholipase C gets activated, that is IP3DAG, and there is release of calcium, which brings about the phosphorylation of various enzymes. And there is direct action on the ion channel opening, and that brings about a different kind of action. So if you see here, when we come back to the question here, so you can see here ligand A increases the intracellular calcium, so that will be GQ. Ligand B decreases the cyclic AMP, that will be GI, and ligand C increases the cyclic AMP, that will be GS. So GQ, GI and GS is the answer. Okay. So that is regarding the G protein coupled receptor. So remember, most common, it is fast acting but not the fastest acting. You can remember the shape, heptahelical serpentine. There is a GDP attached to it, which gets converted into GTP when it is activated. You have different subtypes, GI, GS, GQ, G1213 and GO. Okay, now what I'll just briefly tell about the other receptors also, as I told earlier, which is the fastest. It is inotropic. You can see here the receptor, there is ion channel surrounding it. So when the agonist binds, there is opening up of this ion channel. So that is why, and there is influx of these ions. That is why it is fastest acting. Then you have your G protein coupled receptors, which result in G protein activation and the second messenger signaling pathway, and there is cell signaling. Then you have the enzyme linked receptors like your tyrosine kinase receptors. So you can see here, when the ligand binds here, there is dimerization of the receptor that is happening. That will result in phosphorylation of tyrosine and there is activation of the cell signaling. In case of nuclear receptors, when the agonist binds to this receptor that are either present on the cytosol or the nucleus, the complex will come and they change the DNA transcription and result in translation. So it is important to know the key examples of each of these types of receptors. So when you come to inotropic receptors, you can see the nicotinic receptors, the GABA A receptors, the glutamate receptors, NMDA, AMPA kinase, and the serotonergic receptors are all examples of inotropic receptors. G protein coupled receptors, you have seen alpha and beta receptors are the most important one. The enzyme linked or tyrosine kinase, you can remember PIG. So P for prolactin, I for insulin, G for growth hormone. In addition, you have growth factors like EGFR, VEGFR, HER2 and IGF-1. Now, nuclear receptors, we can divide them into cytosolic and nuclear receptors. In general, we call them as nuclear. This is based on the position of the receptor, whether it is present on the cytoplasm or within the nucleus. You can remember by the mnemonic CD, PSVT. C for corticosteroids, which includes glucocorticoids and mineralocorticoids. And D stands for vitamin D or calcitriol. PSVT, P stands for PPAR alpha gamma receptors. S for sex hormones, estrogen, progesterone, testosterone. V for vitamin A or retinoic acid. And T for thyroid hormones, T3 or T4. Okay. Okay. Now we go to the next question. Which of the following drugs does not follow zero order kinetics? So we are coming to another term, that is zero order kinetics. So what are the two different types of kinetics of elimination? You have first order kinetics, right? And you have the zero order kinetics. You have one more which are called as mixed order kinetics, which follows both first and at high doses it follows zero order kinetics. Most of the drugs follow which order of kinetics? It is the first order kinetics. There are only few drugs that follow zero order kinetics. So let's see what they are. Now, among this, the warfarin, phenytoin, aspirin follows zero order kinetics. It is a sodium valproate that follows the first order kinetics. So that is the answer. What is a mnemonic that you can remember? It is the 0 watt power. 0 stands for the zero order kinetics. Watt for warfarin, A for both alcohol as well as aspirin in high doses, T for theophylline, another T for tolbutamide, P for phenytoin. Phenytoin again, it shows mixed order kinetics. At low doses, it shows first order kinetics. At high doses, it shows zero order kinetics. So, so you have to remember these drugs. Warfarin also at low doses it shows first order kinetics, high doses it shows zero order kinetics. Zero order or pseudo zero order kinetics, they are also called as, they follow saturation kinetics. That is when the enzymes that metabolize these drugs get saturated. Usual site is in the liver. When it gets saturated, then the drug follows zero order kinetics. So that is why it is called as a saturation kinetics. So what is the basic difference between first order kinetics and zero order kinetics? In first order kinetics, remember F for fraction. Okay, it is a constant fraction of a drug is getting eliminated if the drug is following first order kinetics. Whereas in zero order kinetics, it is a constant amount that is getting eliminated when the drug is following zero order kinetics. Let's see with an example. For example, if you are taking 100 of molecules of a drug, if it follows first order kinetics, and if you consider 50% of it is getting eliminated in a unit hour, what will happen in 1 hour? 50% is getting eliminated. So it gets reduced to 50, right? In the next hour, again 50% of it is getting eliminated. So what will happen in next 1 hour? 50% of 50 gets eliminated, which is 25, right? Again, next 1 hour, what happens? 50% of 25 gets eliminated. Again, next 1 hour, what happens? Again, 50% of 12.5 is getting eliminated, and so on and so forth. Now, if the same thing that happens in zero order, if we consider a zero order, if a drug follows zero order kinetics, it's a constant amount that is getting eliminated. For example, if 20 is the drug that is getting eliminated in unit time, after 1 hour, you get 80. Okay. Next 1 hour, again 20 is getting eliminated. What you get is 60. Again, next 1 hour, 20 is getting eliminated. You get 40. Again, next 1 hour, 20 is eliminated. and you get 20. So it is a constant amount that is eliminated, not constant fraction. If it was constant fraction, if it was 20% that was get eliminated, 1 hour it would be 80. The next hour it will be 20% of 80. That is around 16. So 64 will be remaining. So that is the difference between zero order and first order kinetics. So there are certain things that you should remember the difference between the first and the zero order. The first thing is regarding the, let's say, rate of elimination. Okay, let's see what happens rate of elimination in first order and in zero order. Okay. So what is meant by rate of elimination? It is the amount that is getting eliminated in unit time. So what is the rate of elimination here? How much is getting eliminated? It is 50 in 1 hour, right? Here 50 to 25, it is 25 in 1 hour. Here 25 to 12.5, it is 12.5 in 1 hour. Here it is 6.25 in 1 hour. So here you can see that it is 50, 25, 12.5, 6.25. The rate of elimination is proportional to the plasma concentration, right? Whereas here, what is the rate of elimination? You can see here, it is 20 per 1 hour. It is again 20 per hour. It is again 20 per hour. It is again 20 per hour. So here the rate of elimination is constant. In other words, what do you say for rate of elimination? Is directly proportional to the plasma concentration to the power of order. In case of first order, plasma concentration to the order of 1, which is plasma concentration. So here it is directly proportional to plasma concentration. In zero order, plasma concentration to the order of 0 is a constant value. That is why in zero order rate of elimination is constant. So that is regarding the rate of elimination. Another thing that you should know is about the clearance. Now, how do we calculate the clearance? Clearance is calculated by dividing the rate of elimination by plasma concentration. So here you can see it is 50 by 100, which is 1 by 2 or 0.5. Here you can see the rate of elimination is 50, here it is, rate of elimination is 25 by 50, which is again 1 by 2. Here it is again 12.5 by 25, again 1 by 2. Here it is 6.25 by 12.5, which is again 1 by 2. So you can see here clearance in first order kinetics is remaining constant. Okay. Now what happens to clearance in case of zero order kinetics? So here you can see it is 20 is the rate of elimination by plasma concentration by 100, that is 1 by 5, which is 0.2, right? Here you can see it is 20 by 80, which is 1 by 4, which is 0.25. Here you can see it is 20 by 60, that is 1 by 3, 0.33. Here it is 20 by 40, 1 by 2, 0.5. So you can see here as the plasma concentration decreases, the clearance is increasing. Or in other terms, the clearance is inversely proportional to the plasma concentration, right? So when the plasma concentration is high, the clearance is low. When the plasma concentration is Just 1 minute technical break. Sorry for that disturbance. So you can see here, when the plasma concentration is high, the clearance is low. When the plasma concentration is low, the clearance is high. So that is regarding the clearance. Okay. Whereas clearance in case of a first order kinetics, it is constant. Next, we come to one more component, that is what is known as the T half. What is T half? The time taken for the drug to become half its initial concentration. So here you can see the D half at time taken for the drug to become half. Here is 1 hour. Again from 50 to 25 it has taken 1 hour. 25 to 12.5 it is 1 hour. So in case of first order kinetics, the T half is same or constant. Whereas let's see what happens to T half here. Time at this point for 100 to become 50, it took around 2.5 hours. From 80 to become 40, it took 2 hours. At this point, from 60 to become 30, it took around 1.5 hours. So what you can see here is T half is not constant, or in other words, it is directly proportional to the plasma concentration, in the sense when the plasma concentration is high, the T half is also high. When it is low, T half is also low. So these are the key important differences between the first order kinetics and zero order kinetics. Remember, in first order kinetics, it's a constant fraction that is getting eliminated. In zero order, it is a constant amount of drug that is getting eliminated. So if you remember that, you can remember the remaining concepts. So you can see here, the rate of elimination is proportional to the plasma concentration in case of first order. It is independent or it is constant in case of zero order. Clearance and half-life is constant in first order, whereas it is not constant or variable in case of zero order. Okay. So that is regarding the first order and zero order kinetics. So let's go to the next question. A 65-year-old man with hypertension and chronic stable angina is started on a thiazide diuretic. 2 months later, he develops joint pain and swelling in his right big toe. Lab testing reveals elevated serum uric acid levels. Which of the following best explains the mechanisms by which the thiazide diuretics increase the risk of hyperuricemia? So, what is this patient having? Hypertension and angina, and he is on thiazide diuretic. And what has he developed? The pain and swelling on the right big toe, and that is because of he has developed acute gouty arthritis, and which is confirmed by elevated serum uric acid. And the question here is, what is a mechanism by which the thiazide diuretic causes hyperuricemia? So basically, what happens is it because of decreased reabsorption of sodium leading to increased uric acid reabsorption? No. It is because of renal organic anion transporter inhibition, thereby decreasing the uric acid excretion from the body. Hence, the uric acid is retained within the body, that is leading to uric acid level increased hyperuricemia and acute gout attack. Does it cause inhibition of uric acid synthesis? No. Or stimulation of the organic cation transporters in the proximal tubule is also not the answer. So you can see here, the tubular secretion is a energy dependent process which is mediated by transport system. So you have a transport system for acidic drugs as well as a transport system for basic drugs. So remember, the GFR is dependent on your plasma protein binding and your blood flow and all, but tubular secretion has no effect whether it has lipid solubility or plasma protein binding, does not have any effect on the tubular secretion. Why? Because it is an active process which is energy dependent with the help of various transporters. Okay. So here you can see on the renal proximal tubule, you can see here, this is the lumen of the proximal tubule where you have the renal filtrate. This is the other side, the basolateral side where you have the blood and all. So you can see here there is an organic acid transporter. So there is a competition between hydrochlorothiazide and uric acid. And the hydrochlorothiazide is getting, it's an organic acid and that is getting transported. Uric acid is remaining here. So the tubular secretion of uric acid is inhibited by the competition of this thiazide with the organic acid transporter. Hence that results in hyperuricemia and gout. One more possible mechanism is this organic acid, usually the uric acid is exchanged with the anion and it gets reabsorbed. So this hydrochlorothiazide, since it is an organic acid, can facilitate this process also, and that is also one of the reason that can cause hyperuricemia. But the most important mechanism is inhibition of this or competition with this organic acid transporter and increasing the uric acid levels that leads to hyperuricemia. Now, in case of lithium, there is another drug interaction between lithium, which is because when there is a when you are giving hydrochlorothiazide, what happens? There is increased loss of this sodium and water. And what does the body tries to do? It tries to reabsorb because of the feedback, and to maintain the homeostasis, the body tries to reabsorb the sodium, and along with sodium, lithium also, which is a monovalent cation similar to that of sodium, the lithium also gets reabsorbed. And since lithium has a narrow safety margin, that can lead to lithium toxicity. So that is another drug interaction of lithium and thiazide. Okay, so here it is inhibition of the renal organic anion transporter, decreasing the uric acid excretion. Okay, so let's move to the next question. In the given Micheli's-Menten enzyme kinetics graph, comparing curves A and B with the normal enzyme curve, which of the following statement is correct? So you can see here, this is a normal graph. There is another graph that is in presence of an antagonist to the enzyme, and there is another one that is A. Now you can see here there is rate of reaction is there on the y-axis and the substrate concentration is given on the x-axis. Now let's see the options. Curve A shows increased Vmax, decreased Km. Curve B shows decreased Vmax and increased Km. So before we go through the options, we need to know what is meant by this Vmax, what is meant by Km, and what is the difference between what happens to this Vmax and Km if there is a competitive antagonism of those enzymes and if there is a non-competitive antagonism. So first let's see what is meant, then we'll come back to this graph, then it will be more easier. It is almost similar to competitive and non-competitive antagonism at the receptor level, but this is happening at the level of enzymes. So what is Vmax? Vmax is it is the maximum velocity at which the reaction happens is what is called as the Vmax. So let's see what is competitive antagonism, and in competitive antagonism what happens to this Vmax. So what is competitive antagonism? Here there is a enzyme. Enzyme naturally has got a substrate. For example, acetylcholine and cholinesterase. So cholinesterase, normally it binds with acetylcholine and metabolizes it to acetate and choline. So here we are giving physostigmine. Physostigmine is an anticholinesterase. So that has very much similar to that of acetylcholine. So instead of acetylcholine, this physostigmine is coming and binding at the same active site. So the drug is competing with a normal substrate for the active site. So you can see here, instead of substrate, it is the competitive inhibitor that is coming and sitting inside the active site. Okay, so that is what is meant by competitive antagonism. But if you increase the substrate concentration, it can displace this antagonist from the binding site. So that is why it is called as surmountable inhibition. Okay, so example is physostigmine with acetylcholine for the cholinesterase, atorvastatin inhibiting HMG-CoA reductase enzyme, which is a key step in cholesterol synthesis. Now, what happens to this graph in presence of a competitive inhibitor? So, what is Vmax? I've told earlier, it is a maximum velocity that is attained. It is similar to efficacy that we have seen in the log DRC. That is a height is what is giving the Vmax. Okay, so this is a Vmax, that is a maximum velocity attained is what is called as the Vmax. Now, what is Km? That is the concentration that is required to achieve half the Vmax. Okay, the substrate concentration at half maximal Vmax is what is called as the Km. Now, in presence of a competitive inhibitor, what happens? If you increase the dose of the substrate, you will be able to achieve that maximum rate of reaction. That means the Vmax is not changed in case of competitive inhibition, but what happens, you require a more substrate concentration to produce the same response. So the Km increases, Km is increased, Vmax is not changed, as still full enzyme activity is attainable provided you increase the dose. So just like in case of competitive antagonism, in case of receptors, we say the efficacy is achievable, but the potency is decreased. There is shift of DRC to the right. Similarly, the Vmax is no change, but the Km increases, or in other words, you can remember it as in competition, you have to run kilometers. So the Km stands for kilometers. You can remember like that, and Km increases in case of a competitive antagonism. Okay. Now we come to non-competitive antagonism. Before that, let's see some examples of competitive antagonism. So we have seen here physostigmine, that is against cholinesterase enzyme. We have seen atorvastatin against HMG-CoA receptors, moclobemide, which is a MAO-A inhibitors, carbidopa bensericide, which is dopa decarboxylase enzyme, which we use in Parkinsonism, allopurinol, which is a xanthine oxidase inhibitor. What is xanthine oxidase? It is an enzyme that is involved in synthesis of uric acid. So it decreases uric acid synthesis. Then you have captopril that inhibits angiotensin converting enzyme, finasteride that inhibits 5-alpha reductase enzyme. Where do we use finasteride? We use it in benign prostatic hypertrophy to decrease the prostatic volume, muscle volume, by decreasing the effect of testosterone. Then we have letrozole, anastrozole, which are aromatase inhibitors. Then sulfadiazine, which inhibits the folate synthase enzyme. So these are all examples of competitive antagonism. Now we come to non-competitive antagonism. So what is meant by non-competition? So here it is not binding to the active site. You can see here the active site is free, but it is coming and binding to the allosteric site. And this binding will change the shape of the enzyme. So some of the enzymes have lost their activity. So even if you increase the concentration of the substrate, the maximum rate of reaction or maximum reaction velocity is not achieved. So Vmax is definitely going to decrease. So here just like your non-competitive receptor antagonism. So here the inhibitor reacts with the adjacent site, not the catalytic site, alters the enzyme and it loses its catalytic property. Examples are acetazolamide, which is the drug that we use for acute congestive glaucoma. It is against carbonic anhydrase enzyme. Disulfiram, which inhibits aldehyde dehydrogenase, which we use for alcohol dependent patient. So if you look at this graph, you can see here in non-competitive antagonism, there is decrease in the Vmax, because however much you increase the substrate concentration, you will not be able to achieve at maximal rate because some of the enzymes have lost their catalytic property. But you can see the half maximal velocity, the concentration at which you get the half maximal velocity is not changed. So there is no change in the Km, but there is decrease in the Vmax. So these are the examples of non-competitive inhibitors. We have seen acetazolamide on carbonic anhydrase. You have aspirin indomethacin on cyclooxygenase, disulfiram on aldehyde dehydrogenase, omeprazole acting on H plus K plus ATPase enzyme, digoxin on Na plus K plus ATPase enzyme, theophylline on phosphodiesterase, propylthiouracil on peroxidase, lovastatin on HMG-CoA reductase, and sildenafil on phosphodiesterase 5. So these are examples of non-competitive inhibitors. Now there is one more phenomenon which are called as irreversible competitive inhibition. So here the substrate is binding to the enzyme at the active site only, but this is with irreversible linkage, that is very strongly, so that it cannot be displaced even after a large amount of substrate is added. So it is a competitive inhibition, but it acts like a non-competitive inhibitor. So what happens, even if you increase the concentration of substrate, some of the enzymes is not able to bind because it is still bound with the inhibitor. So here what happens is Vmax also decreases, the Km rises as in case of competitive, but the Vmax also decreases just like in case of non-competitive inhibition. This example is organophosphates and acetylcholinesterase. A similar example in case of receptor antagonism is what we call as non-equilibrium type of inhibition. So in case of phenoxybenzamine, it binds with this alpha receptors with alpha receptors. It binds with strong covalent bond such that even if you increase the concentration of the substrate, it will not be reversible. That is what is called as non-equilibrium type. It is actually competitive non-equilibrium type because it is binding to the same site. We call it as competitive, but we may classify them under the non-competitive antagonist because they behave just like a non-competitive antagonist. So there, if you plot the DRC, you can see there is shift to the right as well as there is flattening of the DRC. Both the actions are seen in case of a in case of a irreversible inhibition. So this is a difference. You have competitive and non-competitive. Competitive, it binds only to the enzyme. Here both to the enzyme and enzyme substrate. The drug should have similar structure, no similar structure. Inhibitor binds the active site to an allosteric site, which is surmountable. Competitive inhibition is surmountable. Here the inhibition is insurmountable. And the importance here in competition, there is increase in Km but does not affect the Vmax. Here the Vmax is decreased but does not affect the Km. So let's go back to the question and now let's find out what is the answer. So you can see here, what are the options? Here you can see what has happened. It is just the direct question that is being asked. A, what do you see? There is a decrease in the Vmax, but Km is remaining the same. In case of B, you can see the Vmax is remaining the same, but the Km has increased. So which is the answer that shows similar response? You can see curve A shows decreased Vmax. Curve A shows decreased Vmax and normal Km, and curve B shows normal Vmax and increased Km. Okay. So that is the answer. C will be your option, right? Curve A shows decreased Vmax and normal Km. Curve B shows normal Vmax and increased Km. So option C is your answer. Now let's take a short break.